Hi, I'm Julia Brody at Silent Spring Institute. I'm honored to be on a panel with Trevor Schaefer and grateful for his work. I noticed in Mr. Schaefer's testimony for Trevor's Law that he described how experts had patronized his mother when she asked questions about cancers in their community. So I'm here to talk about having a different conversation, one that acknowledges uncertainty and limitations, but focuses on what we do know and can learn about cancer, about the causes of cancers. My focus is in particular on how to report back individual level results in investigations that involve emerging science. Community cancer investigations often include measurements to evaluate exposure patterns, including biomonitoring for chemical exposures in people's blood, urine, or other tissues, or sampling in personal environments or detailed assessments of geographic data. These measurement technologies are expanding rapidly, as you can see from the topics in this workshop. Scientists and health officials understandably may feel uncertain about communicating with study participants and community members when they don't have established health guidelines to apply to the measurements. But we do know that people want their results even when the relationships to health are uncertain and the action implications are unclear. A consensus panel on biomonitoring in 2018 concluded that reporting back is an ethical responsibility to respect the autonomy of people who participate in investigations. The new CDC guidance also emphasizes the value of transparency to build trust. And I would add that report back can advance equity and environmental justice by opening access to science in communities that are under-resourced and affected by structural racism. And I would add that these investigations and the interaction between researchers and study participants can support recruitment and advance discovery through revealing unexpected sources of exposure. But interviews with researchers have found that lack of resources to personalize reports and lack of the multidisciplinary expertise to create reports have been the major barriers to expanding this practice. So my team developed Derby, the Digital Exposure Report Back Interface, as a software framework to generate personalized exposure reports for computer, smartphone, or print in studies of any size. It includes a researcher dashboard to create reports using user-tested platforms and adaptable text and images to tailor reports to community context and language. A key feature of the reports is a results summary page that generates personalized headlines that draw attention for each participant to notable results from their samples. For example, this report says your sample had a higher level of a bisphenol than 95% of Americans, drawing on the comparison to the National Health and Nutrition Examination Survey, NHANES. Summaries include overall study results as well as individual results. And then users can click through to visualizations of all of their chemical results in comparison with others in the study and to benchmarks chosen by the research team. The design uses a concept called details on demand that allows users to navigate to the type and amount of information that they want so that reports can be complete without seeming overwhelming. So typically users will click on one of their headlines and then see a detailed page about a particular group of chemicals in their sample, including information about the chemical sources, what's known about the health effects, exposure reduction strategies, and then below this text, they'll find their results graphs. They can also navigate to answers to common questions and background information about the study and its methods. Reports are smartphone friendly, and this expands access in low-income communities where smartphone is the primary access to the internet. In addition to this background information about individual results, the reports support major messages to advance environmental health literacy and offer transparency about uncertainty. For example, reports might say something like, chemicals in the study have been detected at different levels in people throughout the US. Detecting these chemicals doesn't mean you will get sick. Or they might say something like, so far, studies of people have found that higher levels of PFAS are linked to increased cholesterol levels, decreased vaccine response in children, and so on. Based on what we know now, we can't link your results to specific health concerns for you or your family. And we find people readily understand messages like this. We also explain the kind of evidence we use in environmental health. For example, since we don't do experiments on people, we often learn how chemicals may affect health by testing in animals or cells, similar to the way we test new drugs for safety. Individual results, of course, will be returned in a broader context that may include community meetings, interactions with news media, action on social media, and sometimes clinical care. So results reports need to be integrated into this broader context. I applaud all the calls for additional training of doctors in environmental health, but we've been taking the approach of trying to provide resources for the patient to make these conversations more successful by providing information within the individual reports that help people prepare for these conversations and bring the information that doctors will need. Community digital resources can also include online platforms like PFAS Exchange, which connects community groups in different communities that may be affected by the same types of exposures. This resource also allows people to enter personal drinking water results or drinking water from a public supply. So I encourage you to go check it out. Now a word about things not to say. When faced with worrisome news, like unusual instances of cancer in a community or unusual exposures, there's a natural impulse to reassure, often by focusing on uncertainties and what we don't know, instead of focusing on what we do know. But cancer is a disease with long latency and multiple complex risk factors. It's unethical to conduct experiments to test the effects of harmful chemicals in people. And that means we should not set expectations to look for proof before we take action to protect health. So I'd like to eradicate all sentences that begin, there's no proof that XYZ causes cancer. Unfortunately, we find that there are many instances of false reassurance on websites that should be authoritative. For example, the National Cancer Institute says even if a chemical is shown in a laboratory test to cause cancer, this does not necessarily mean it will cause cancer in people exposed to that chemical in the environment. It's true, but it's not helpful and it's misleading unless the next sentence says, often chemicals that cause cancer in lab tests do also cause cancer in people. That's why US EPA and FDA use this information to make decisions to keep us safe. Before I close, I want to note that the research that I've talked about here originated from a community cancer investigation on Cape Cod, Massachusetts. Rates have been elevated there since the 1980s, and that continues to be the case. In the 1990s, 3 data sets showed that established breast cancer risk factors did not explain this higher risk. And extensive environmental investigations were conducted, including the household exposure study, which led to the discovery that consumer products and indoor environments are major sources of exposure to endocrine disrupting compounds. This work has been cited more than 1,000 times and contributed to product reformulations and chemical regulation changes. So I am encouraged that community cancer investigations can contribute very important science that can help all of us advance public health. I hope you'll visit some examples of personal exposure reports on our website. There's also a bibliography of more than 25 peer-reviewed publications on this topic. I'm very grateful to my multidisciplinary, multi-institution team and to support from the National Institutes of Health, National Science Foundation. CDC and the California Breast Cancer Research Program. And I thank you very much and look forward to the discussion.